All right, everyone. Well, it looks like we've come to a standstill in the waiting room, so we can go ahead and get started. Welcome to session 3 for our foundational community supports Medicaid Academy. We're very excited to have you here. Today, we'll be talking about staffing models, cost estimates, revenue projections, all for Medicaid reimbursement. You should have received the slides via email. You should have also received tools that will accompany the training via email. And hopefully you all have access now to the SharePoint drive. Of course, if there are any issues with accessing that, you know how to reach me. So, as usual, I just want to reinforce that the views, opinions, and content expressed herein do not necessarily reflect the official position of the Department of Behavioral Health and Recovery or the Healthcare Authority. And as a refresher, today your team will include an executive lead, program lead, fiscal lead, and quality lead. As a reminder, smaller organizations may have the same person playing multiple roles, and that is totally fine and completely understandable. We are here to equip you with the tools that you will need to play these different roles within your organization. And in case you don't remember, your training team consists of Marcella and myself. And I know you still haven't met Terry Power yet. You will be meeting her next session. So again, the purpose of today's Medicaid Academy learning sessions are really to equip you with an understanding of how FCS is overseen by the Healthcare Authority of Washington and the FCS team. So HCA provides the policy requirements for the FCS program, whereas the FCS team will help you actually implement and develop a plan for your agency. The state and Amerigroup's various information on FCS is available and linked in this slide deck, which you should have received. And of course, each session includes helpful tips and tools, opportunities for sharing information across your agencies, and general technical assistance. Today, as I mentioned, we will be discussing staffing and budgeting, and then this coming Thursday will be our first TA session. It will offer you opportunities for Q&A. So if you've missed any previous sessions, you can review the slides and come prepared with questions. If there was any information that was unclear to you, or you are wondering how you can apply some of this information or use the tools that we've offered within your own agency, this is an opportunity for you to work directly with us to implement the information that you've been hearing. So we really hope that you're able to join us. We've received feedback in the past from other Medicaid academies that this is an extremely valuable and useful opportunity for providers to really get down and dirty with material and ask any questions that come up. And with that, I'm going to pass it over to Marcella, who's going to take you through today's training.
All right. Thanks, everybody. Thanks, Eva. Thanks, Ryan, and everybody. And excited for today's conversation. Also, the chat's enabled. So if you've got any questions, just jump in the chat here. Eva, if you notice it and I'm on a roll and don't stop, please make sure jump in with these questions. There's about 40 people here today, so I hope we can have a little bit more of a dialogue there. And Ryan's got the housing support contacts in there as well, and for Dawn for supportive employment. So right now we're going to talk about, remember, our goal of the Academy is very much focused on the administrative aspects of Medicaid. We're assuming you come knowing how to deliver the services, or there's other trainings for that. This is really on those administrative aspects of the program. And in particular, we want you to build a fiscally sustainable program. Agencies can't afford to lose money on programs. They operate with very small margins. I like to say none of us goes into this work to be rich, but all of this stuff, all of us do need to get paid. So we're going to talk about the different service models and service alignments, some tools and strategies that you can use in order to work that, and make sure that your Medicaid eligible and enrolled tenants, you're able to bill for the services and have that sustainable program. We recommend that all of your agencies have a good understanding of what's called your total cost of care. Total cost of care means what it truly costs to deliver the service, so that it costs A to do this work. We need to get paid at least A in order to be able to break even and be able to have those conversations with different funders and different payors. We're going to talk about different staffing models, and we've got a couple of different services budget tools, a simple budget tool that Ava shared with you, which looks at basically direct services staff, making sure direct services staff costs are covered, and then a broader services budget tool that looks at every little place where there's going to be a cost to something and make sure that those costs are covered within your agency. We're going to have a little bit of time, we hope, to use the services budget tool and the time study tools and revenue projection tools as well. We have to think about these things, and today's conversation is all about thinking about things in fiscal terms. I know our goal here is really to deliver quality services to help people gain and keep employment, to help people gain and stabilize in housing, to help people improve their health and other outcomes in their lives so they can be thriving members of our community. But again, the foundation of all of that is many of the administrative and budget aspects we're going to talk about here. So next slide, please. So one thing that's a real shift for agencies that have operated in the grant world, and this is important for you to understand, is that it's a shift about how you get paid. And it's a shift in when you get paid as well. CSH estimates that the time it takes from an agency that says, hey, we should do a Medicaid service, to the amount of time when you have a functioning fiscally sustainable program, 100% covered by Medicaid or close, is about an 18-month period. You've got to think from a budget perspective about how you're going to prepare for that time period. So think about it this: in the grant world, administratively, you write the grant, you get the award, i.e. you normally get paid, you do the work, you do the direct service there, and then you write a report to the funder about what it is you did, and maybe you start the circle again about writing another grant for additional work here, etc. The healthcare world administratively is fundamentally different. You have to enroll as a provider in Medicaid. You have to incur costs while you're doing that. You have to get an agreement with managed care, or in this case, Amerigroup for FCS, et cetera. You do the work. So you've hired people, you've trained them, they do the work, they submit the claims for these people, and then you get paid. So this time period in there's a lapse where you really have to think about how are you going to cover. That's that 18-month period where in month 1, you're not bringing in any funding. In month 18, you're probably bringing in as much as you need, and it's a gradual process from here to there. So you've got to prepare administratively for how you're going to, as an agency, make it through this time and make it through this process. I say administratively, but I also mean fiscally. This really develops a cash flow issue that agencies need to be prepared to think about. So next slide, please. So important things to consider. Next slide, please. So foundational community supports are covered in what we call rates. You do not get one lump sum to do the work as you're doing a grant. You get reimbursed. For supported employment, you get reimbursed on a 15-minute unit of service that you're paid $27 for that 15-minute unit of service. You're limited to 120 units of service. That means 120 15-minute periods, 30 hours, a period over 6-month grant authorization. Services need to be reauthorized. Services are generally authorized in a 6-month period. When they need to be reauthorized, it doesn't mean they don't need help anymore. It doesn't mean the person doesn't need assistance. It doesn't mean the program for them is ending. It just means you need to make a case to Amerigroup about why the services are continued to be needed. There is also an exception of the rule authorization process that if you need more than those 120 units of service, 30 hours of service in order for the person to meet their goals on their person-centered plan, on their service plan, then you can ask for that as well. Again, but you've got to make a case. Why does this person need additional help? So this is off the supported employment benefit, 1 unit of service for 15 minutes, 30 hours of service, 30 hours of service over a 6-month period. If people need more, you can ask for more, but you've got to make the case. And when the time period ends, it's in some ways an arbitrary time period. You're just coming back and saying, Marcella got this help, she got in her housing, she was able to put together a resume, but she hasn't been able to get a job yet. She's been going around and we've been supporting her in that process of applying for jobs. She hasn't been able to get employment, and we know she's going to need coaching to keep employment. Then so we need additional services. So you've got to be able to understand and be able to make that case. Supportive housing benefits a little bit different. It is on a per diem rate. That means that you can bill for 30 days of service. Doesn't mean you spend every minute of the day or even 8 hours of the day with a person. It means you've spent some time with the person working on their goals around their supportive housing person-centered plan. You again are limited to you're in a 6-month authorization period. When you submit your claims, you're going to need to have an authorization number, and that authorization number needs to go on every claim that you've gotten from Amerigroup, and we'll cover this in the billing session. You're reimbursed at $112 a day. Again, like supported employment, services may be reauthorized at the end of the 6-month period, but again, you've got to make the case. And then you also have the exception of the rule process. If somebody needs to be seen more than 30 days in a 6-month period, you just have to make the case about why that is. When you are reimbursed by Amerigroup, they're paying you for a lump sum of 15-minute units of service, or you've seen this many people at this many days, and this is giving you this funding there, then you use that to pay your bills. People say, and what do we use the money for? We're like, pay your staff, pay your bills, do those things. It's agency revenue. Agencies can do what they need to do, but they have to sustain the program over time. So these are the currently effective rates in place. And this is also why we want agencies to begin to, and we'll give you some tools to help you estimate your total cost of care, what it costs to truly do the service, because you want to be able to say, this is how often we see people on average. You want to do this in a data-driven way. We see this many people a day. We see this, cover this many people in services in general. We generate this much revenue. This is enough revenue to cover our costs, or this isn't enough revenue to cover our costs. Inflation is happening. We've had to raise salaries to recruit staff. We've got other sources of revenue. I'm sorry, not other sources of revenue. And so you really want to be able to make that case about this costs A, we're going to need to be generating this much revenue in order to do a quality service over the long term. Again, no one wants to get rich, but everybody does want to pay the bills. So next slide, please. So how do you think about as you're beginning this FCS journey? We want your agency to be able to estimate new Medicaid-related agency costs. There may be some staff that you haven't had to have. You may not have had to have a billing system. You might not have had to be HIPAA compliant in your whole system. You may not have to have a quality assurance person. You might not have to have a quality plan. You're going to need these things. These things cost staffing time and therefore money. So we want you to be able to estimate what those costs are and figure out how those costs get covered. We're going to talk about, for supported employment services, we're going to talk about a time study and how to estimate your billable revenue and how to begin that process. We understand total cost of care, and I've talked about this a little bit. We want your agencies to be able to develop a work plan. This is not a one and done process. This is often not a one person and done process. This is something that impacts all the different pieces throughout your agency, and we think it's really helpful for agencies to have a long-term work plan in order to really break down each of these pieces and how your different staff, your quality staff, with your fiscal staff, with your program staff, with your leadership, all work together in order to build that fiscally sustainable program. And they want everybody on the team to have at least a basic understanding about what, including tenancy support services and supportive employment services, what it costs for your agency's bottom line, how my actions today, how my documentation, how my delivering service impacts my agency's bottom line, contributes to, how I have my job, how all of us at our agency have our jobs, and how we're able to go on and continuing to deliver the services. As social workers, as psychologists, that's my background. We really often just want to help people. We don't think about things in these fiscal ways, and a couple of people in our agency have to do that. And so it's really making that shift in order to hold up quality services as really a central piece of what you're doing, but as a central piece of your goal and why you're doing the work, but also making sure, as I said, you've got a fiscally sustainable program. So these are all questions that you're going to have to be able to answer. Staffing is going to drive that, because for all of us, I think our biggest single cost is personnel. So next slide, please. So we're going to think about the 4 lenses of estimating costs. And these are 4 different places where we talked about the 4 lenses before, about you have to think about how Medicaid changes your program, how Medicaid impacts your program from these 4 lenses. And I'm just going to talk about a couple of different places where we find all of these are activities you need to do to build a Medicaid program. And all of these are places where they generate costs, and therefore you want to look at what revenue you're going to be able to generate to make sure those costs are covered. Service provision, direct services staff. Start with that one because it's the biggest single, biggest thing is cost item we have. Staffing and supervision. It's not just the direct services staff, it's their supervision, it's their training, it's their support, it's compliance requirements, making sure that someone's looking at your compliance work, looking at your documentation and making sure that documentation is compliant. Medicaid has the process that if something's not documented correctly, Medicaid has a process what they call claw back, meaning if an audit comes in and an audit can't find the documentation that we billed for services with Marcella on October the 18th, and we have documentation for that, Medicaid has the right to claw back and say, we paid you for that, but you can't document it. We're taking that money back. So we want you to have compliance processes in place so that never happens to you. That is certainly a goal. These are other places where you've got costs. Business partnerships. How are you partnering with the housing partners in your world? How are you making sure, how are you partnering with the jobs, the landlords, the employment agencies in your community? What partnerships are you building there so you can be successful in your projects? Strategic long-term planning. How do you see growing your agency over time? You may be braiding funding streams. Your partners may be braiding funding streams. We're talking just about Medicaid here, but you've got other compliance requirements from HUD or other housing-related services. How do you think about that? And then board governance. How do you make sure your board has the right people on it? Nobody understands all of these pieces. You want people on your board supporting who understand each of the aspects of this work, who are experts, who have networks and connections and can support your work going forward. So that's also could be a cost to you as well. There's logistical cost, financial operations, your financial staff, your billing staff. There's legal agreements. You want your agency's lawyers to be looking over material, things you're signing here. HR, you have to think about it from that an HR perspective as well. And then information technology. What are your systems that you're growing and building? What are you using to document your services? What are you using to bill your services? These are all costs that also have to be factored into what work you're doing. And then finally, analytical. What reporting do you have to do? And therefore, what data do you have to collect? What data management? How do you constantly work on quality improvement of your data, making sure that your data really tells a story, tells the story of what your agency is doing and the difference it's making in people's lives around jobs and housing and employment. Finance staff, operations staff, legal guidance, all of these are analytical perspectives. They all add to costs. They all mean you either have an internal person who's doing your quality improvement work, who's managing your data systems, and that's somebody you're paying, or you're contracting with an outside consultant. You're a small agency. You don't need a full-time person on quality assurance, but you do need a 20-hour-a-week person or a 5-hour-a-week person to look at quality. So you hire an outside consultant to come in and do that work. Again, all of these different costs. So we want you, when I say you want to understand your total cost of care, we often think immediately about direct services staff. That's great. That's probably the single largest line item you have in your budget. But all of these other activities, all of these other staffing roles all have to be considered enrolled into that total cost of care. Some things you need to happen every day. Some things happen once a month, once a quarter, once a year. Again, you've got to think about it from a time frame perspective as well. So using the four lenses here to estimate the costs, because we want you to have a sustainable program. I'll just keep saying that again and again. Next slide, please. So how do we estimate all of these costs? Well, one of the first things we do, we look at our direct services staff, and this is going to be primarily for the supported employment folks here because you're billable in 15-minute times, is two of the materials that Eva sent out this week were a time study, an example form, just like the one you see here, a blank form which your agency can download and adapt for your agency, take out our logo, put in your logo, and then also a narrative that explains what a time study is. A time study helps you estimate on average how much staff, how much activity, how much of what my direct staff are doing a day is billable. How many of those 15-minute increments at $27 a 15-minute increment am I expecting my staff in order to be able to generate? So for example, this is an example of the time study. So what percentage of your staff time is covered by this new funding stream? What revenue do they generate? As an agency, you have to figure out what a target is. You generally speaking, we recommend you want to say to people, we expect 40% of your time or 60% of your time or 80% of your time in order to be billable time. And that's part of the expectations of the job. But you want that grounded, not in some randomly derived number, but you want that grounded in them delivering quality service. So a time study helps you get an exact handle on what your staff are doing in every moment of the day in a general way, not in a very detailed way. Is that time billable? And how many units of service do we expect that you will be generating, that each person will be generating, so that when you choose a number, it's 40%, it's 60%, it's 70%. You choose a number that's based on quality services and staff activity, not a number that you just gave out of the air. So if you see here on our example, we've got a couple of activities going on. At the office, you're filling out an application with Molly. That's 45 minutes that you spent with her. The client was present for that. That's definitely a billable service time, etc. Then you had a staff meeting. That was for an hour. That's valuable time. That's important things that you have to have. That is not billable time. So you see, when I give you my examples of maybe it's 40% of their time billable, maybe it's 60, maybe it's a little bit more. I never said 100 because 100 is never. We think that anything under 80% is probably what you're shooting for. Yes, you're gonna, Nathan, you should have received the slide deck already. You should have gotten an email from Eva Lerner. And if you haven't gotten it, reach out to Eva. Eva, maybe put your email in the chat and we'll make sure that you get the slide deck. So you're thinking about how much time is billable here. I'm never going to say 100%. You're probably never going to hear me say 80% or more, because that's just not possible. People take vacations and they still need to be paid. People have staff meetings. People have supervision. If you're in a rural program and you're moving from place to place, travel is not billable per the federal government. So that's all going to be, thanks, Eva. So that's all going to be important for you to estimate. We've done this in supportive housing programs. You don't need to do this as a supportive housing provider. But you can probably, if supportive housing was on 15-minute increments, you would, and you're in a single site service, you might have 80% of your time because you're just moving between units in one building. But if you're doing scattered site, if you're doing jobs across the community for people, you're not going to be, you're going to be at that lower 40 to 60% number. So you'll be able to generate what kind of revenue. So as I say, it's different for scattered site versus single site programs. It's different for rural programs versus urban programs. You're going to have a lot more travel time, is my guess, in rural programs than in urban. And last week's email included all of these tools. So last week's email includes a blank version of this form, an example version of the form that you see up on the slide here, and a narrative that says, here's how you do this exactly. Here's how you do a time study. We recommend about 2 weeks. We recommend sitting down at a staff meeting and explaining to your staff, we are not checking up on you. This is not some kind of, big brother oversight here. We just want to know, how much time do we think, if you're delivering a quality service, are you going to be able to generate revenue for, so that we can make some revenue projections. The tools that we're going to use later need that number of, we think 40% of their time is billable. We think 60% of their time is billable. You're going to need what that number is. You're going to want projections for your staff to be able to give them and say, okay, you're shooting towards X. You're going to reward them if they're able to do a little bit more than X. You're going to want to have a corrective action plan if they're able to do significantly less than that amount of time, etc. So it's all going to be important from a revenue generation, projecting revenue from a revenue generation perspective. Yes. All right. So next slide, please. That is time studies. Let's see. This is a time study. Oh, time studies also. We've also given you an example here of time study of supportive housing. I do think it's much more important for supported employment when you're generating revenue on the 15-minute increment, that rather than on the per diem billing. How many days a month for supportive housing? I think how many days a month do you expect that the residents will be seen? You're going to do a projection, and then reality is going to come in, and you're going to have to figure out, how many times are we seeing people? What's a good caseload? How many people do our need? How often do people need to be seen? How many staff do we have? How often do they see them? How much time do they spend? And therefore, what revenue are we generating for an agency? Again, we recommend that the agency supervisors direct targets for direct services staff based upon participant need. They generate potential revenue projections based upon that information. We think grounding your program this way gets you away from a lot of agencies, particularly in 15-minute increments, kind of end up chasing units of service and not quality service. And we know that's not what any of us want. We want people to be seen as much as they need to be seen. We don't want them to be seen to be more, because that's wasting time and money. We don't want them to be seen to be less, because that means people aren't going to be successful. You really want to find that sweet spot, and that sweet spot's different for each of your tenants, et cetera. You want a good mix. Nobody wants a caseload to have all, in my system, my old system, we used to have like everybody was scored on an acuity scale of, 1 to 5. Nobody wanted all 5s. Nobody wanted, everybody wanted all 1s. That wasn't good, but we didn't want all 5s either. You want a mix of acuity, how much time people need to be seen, et cetera. So think through these things for your residents, think through these things for direct services staff, set them concrete targets that they know they have goals in order to make, but base it on what they've done here. Help them understand, again, this isn't you, checking up on them. This is you need information to say, okay, what kind of revenue can we generate here given what the rates are? So next slide, please. That is time studies. Questions on time studies, as Eva said, we're going to have a Q&A later this week. You have to think about startup costs. Remember, we keep starting with direct services staff. That's our single largest line item in our budgets, et cetera, but they're startup costs. And remember, we said fee for service, grant, you're not going to get paid until a couple of months down the road, more than a couple of months down the road. What are your startup costs? How are you going to fund your startup costs? We want to give you a couple of things to think about startup costs from a perspective for an agency. One is hardware. You're hiring new staff, so they're going to have cell phones. They're going to have laptops. If they're doing work in an office, you might want sound machines for HIPAA privacy and any office settings. Nobody wants to be able to walk by an office and hear what's going on in that office. You may have vehicles for travel, et cetera, locking cabinets for security for records, et cetera. All of these are hardware costs that are startup, and they're often one-time costs. Software, data collection needs, what's your billing system, how are you documenting your records, how does that generate into the invoices or files that you need to be sending to Amerigroup, how are you collecting that information, you're buying that software. Though I will say, increasingly we're seeing electronic health records and electronic health record companies say, you don't have to pay us an upfront cost, you have to pay us a percentage of your revenue generation over time. That makes them a little more invested in there, so we like that model, though we don't want it to go on forever. You might want that to be like a 5-year plan or a couple of year plan, et cetera, but not forever, because once you do this, you're not going to need as much support. Think about electronic health records in a startup period, and then think about it in a sustainability perspective. You may want to track tenant information, tenant surveys. We'll talk about that in the quality session. And then again, electronic health records, if that's something that your agency is choosing to do. And if your agency is looking and growing in the Medicaid space, this is really an investment we recommend you make that will pay over time. You will also need specific, often consultants, or maybe you've hired somebody internally to lead this work, et cetera, maybe outside or inside, but there's going to be changes that have to happen. You're going to have to revise your policies and procedures. That is literally our whole conversation next time. You're going to have to develop the budgets that we're going to talk about with our tools or someone's tools to do that. You're going to have to understand data collection, and they may help you implement your electronic health record or billing system, et cetera. Audits, Medicaid requires audits. You have to be ready for an audit, to have audit preparation as well. These are fiscal staff. Maybe they're part of your, you're a big enough agency. You've got regular long-term people. This is part of their role, maybe, but their role is going to need to change a little bit because now you're doing Medicaid. For other people, this may be a one-time thing, one-time setup for a smaller agency. So you just want somebody to do it, when those audits are, when you're a month or two out before the audits, but you don't need a full-time person. Again, no right or wrong way for many of these. It's what works for your agency. Next slide, please. So those were one-time costs. Those were, you got to put something out and you'll get something back for it. These are ongoing costs, meaning this is not just in the first year budget. There's some percentage of this that is in your second, third, and your 10th year budget. The percentages may go down, but you know that these are ongoing costs. Staffing, obviously, direct services staff, supervisory staff, administrative staff. Training, making sure that the direct services staff and all of your agency is oriented to those best practices, oriented towards housing first, oriented towards motivational interviewing, trauma-informed care, all of those great models that we know make the difference for people to be able to thrive in our communities. There's business support. Do you have fiscal analysts? Do you have, do you have someone who creates the invoices? How does all that happen? You're going to need business support staff on a regular basis, administrative staff, supervisory staff. That's self-evident. Quality improvement staff. Again, you're a big agency. You may have one person. This is your full-time job. You may have maybe a small agency, and this is something this quality improvement and review is part of the supervisory process. Audit preparation in a small agency may be part of the supervisory process, but just make sure that your staff both have the time. Nobody should have a job at 120% of their capacity, and that they have support in order to do this work. Most agencies now have an IT director. They have data plans. Somebody's got to understand that piece. Somebody's got to help you make choices on that. And these are all ongoing costs that you're going to need to consider. So again, startup costs, what do you need in that first year or two that you really only need in that first year or two? And then what are you going to need every year going forward? That's going to be some percentage of your costs. Things that may or may not be covered in overhead, things that may or may not be covered in fringe benefits. How do you get those costs covered as well? Here's how to think about that. This is how to think about that work. So next slide, please. So we're going to get into estimating revenue. Again, we all got into this to help people, to get people housing, to help people get jobs and keep jobs. But you're going to have to be thinking about this, or somebody's going to have to be thinking about this from an estimating revenue perspective as well. Think about what services are being delivered, what actually is the work that people are doing, what's the type, what's covered under. Is it a billable service? It is not a billable service. That's going to be really, really important to think about that. How volume, how often does it, I'm sorry, how much does it happen in volume? Frequency, how often does it happen? Location. Correct me if I'm wrong, anybody, but I think most of foundational community supports requires face-to-face. There may be some examples of collateral or indirect contact, but that can be limited. And then how does your current practice fit within the state service definitions? Again, what you want to do from a revenue perspective, not from a quality perspective, from a revenue perspective, is you want to find out exactly how much of my current service practice becomes billable time, and therefore how much revenue will I generate keeping those activities going. If you feel like your program's kind of, gotten off track and you want to move it back towards an evidence-based, move it towards a more person-centered perspective, this may be a good time. Yep, thank you. Thank you, Michelle. I appreciate that comment. Yes, you will be getting recordings as well. And also know that sometime in the future, and Rayanne can be more specific on that when she can, there will also be slide decks. I'm sorry, the slide decks and all will be on a Washington State website. Website where you'll have all of these as well. And Rayanne, thank you for jumping in. Phone telehealth collateral is okay. Amerigroup would look for heavy reliance on anything other than face-to-face. Face-to-face is primarily what we're looking for in that time. You also have to look at who you're currently serving. What are their demographics? How are you addressing health equity in your communities? Who's eligible but not enrolled? Who's enrolled? When does enrollment turn over? I will say that this week we learned that the public health emergency is going to be extended until mid-January, January 13th, I believe. This is going to be really important because the states have not been separating anybody from the Medicaid program. They haven't been requiring what's called in the Medicaid space redetermination. Redetermination is a fancy way to say, however, my state requires me to prove that I'm Medicaid eligible so that they will enroll me. I've done that. States haven't been doing that in the public health emergency. Once the public health emergency ends, they're going to be doing that for a lot of people, and people are going to need important support in order to make sure that their healthcare coverage stays on. You also want to think about number of people served by service type and by funding source. Again, you want to be able to have a system that allows you to say, you may work with undocumented people. Those folks are not going to be able to be Medicaid enrolled. You still want to deliver service. You may have other services funding. You want to make sure that that services funding shifts onto the what was I going to say? Services funding shifts to assist them, and the people who can be covered by Medicaid, they are enrolled, and that you are billing for that service. It's really important to think about the fact that if you do a service, if you deliver a service and it's a billable service, but I am not enrolled on the day that you deliver the service to me, then you cannot bill for that service. So you're going to have to be tracking, talked about this last week, you're going to have to be tracking really closely, particularly when the public health emergency ends, who among my tenants or service participants are enrolled in Medicaid, who are not, and what is HCA or APRA Health communicating to them that they have to do in order to keep their enrollment constant. Continuous coverage, that's what we're looking at. So yes, so estimate revenue, think about all of these things, build in some flexibility there. Next slide, please. So these are all things that impact your revenue projections that you might not have thought about if you've never done Medicaid claims before. So we want you to share this information. One, some of your claims may be denied. It's important that you have an internal process that says, these are claims that were denied for reasons that are something that we can go fix. These are claims that are denied that there's nothing we can do about. So that example I just gave you, you deliver service for me, but I'm not enrolled on that day. There's nothing you can do about that. You can go get me enrolled. So whatever you do for me tomorrow will be able to be billable, et cetera, or do with me tomorrow will be able to be billable, but you can't do anything about that. Now, often, but many reasons claims are denied are what we call, just very minor administrative errors, i.e., what's my favorite example? My favorite example is anybody who's named Stephen. If on the claim you spell Stephen Steven, but in Medicaid's computer, Stephen is spelled Stephen. Again, they're both Stephen, they're both right. But in Medicaid's computers, it's spelled with a PH. They're going to kick that back and say, we don't have that person. And they're going to tell you. And you say, no, wait, look, they have that person. You catch that mistake, you resubmit the claim, then they will pay you for that claim. Amerigroup should communicate with you clearly about why claims were denied, but you're going to have to do a little digging as well. Amerigroup, in my example with the Stephen name, is going to kick it back and say, this person isn't enrolled in FCS. You're going to be like, wait, I have that. Why is that? And you're going to have to figure out and go back and look that, oh, you spelled the name slightly differently. Still a common spelling of the name, but slightly differently. So that gives you something you can fix. So think about it for revenue projections from claims denied, and then there are claims you can fix and claims you can't. Some claims may have partial payment, though I don't think that's relevant to this program right here. Medicaid authorization on service lapses. You have to stay on top of when people's Medicaid authorization ends. You have to go back to Amerigroup a couple of weeks, maybe a month before the authorization ends and say, we think Marcella's still going to need these services. Here's our case, here's why, and please enter in an authorization number. If my authorization goes through the 18th of October, and on the 19th of October, and it lapses after that, on the 19th of October, if you deliver services, that claim is going to be denied and there's not going to be anything you can do about it. So you don't want to have times. You want continuous coverage, both from a healthcare coverage point of view, you want people's Medicaid not to lapse, and you also want their authorizations not to lapse, so that my authorization ends today on the 18th for FCS services, but you've already got another one in the queue so that I can be authorized for services on the 19th as well. So don't let those service authorization lapse. Remember, it doesn't mean the service ends. It just means you have to make the case about why people still need the service. Medicaid enrollment lapses, that could be another reason. Delayed reimbursement. Sometimes plans have problems getting out checks. Just think about all of this from a cash flow perspective. And then the rate changes, or if the rate doesn't, rate changes, meaning we generally speaking only see rates go up, but what can be a challenge is sometimes that rates are, rates don't change over time. So if this was a great rate in 2015, but I'm still getting the same thing paid in 2020, that's not a rate loss, but it really from a revenue perspective probably is, because your costs have all gone up. So just think about that as you're building in your revenue projections. Think about this question for you as well, because all of these things are things that external impacts on revenue projections. They're things that you can do internally to minimize the disruption to your revenue generation here, and processes that you need to be aware of, processes that you need to build internally, et cetera. And then there's something that but you may also have some other challenges and things you can't do. So yeah. The next slide, please. Total cost of care. Okay. How do you do? I kept saying you need to do your total cost of care. You're like, yeah, that's great. It would be really good. How do I do that? Okay. Question number one, what's your program budget? That's a part of your total cost of care. Question number two, what staff are revenue generating? Your billing services staff are not generating revenue. Your case managers, your job specialists, people who spend direct service time with individuals, face-to-face time, those are your revenue generating staff. It should be clear for each of the staff role, each of your staff in their job descriptions, are they a revenue generating staff or not? And if there are expectations in regard to how much of their time is billable, how much revenue are they generating, that should be included in there as well, so that people understand that coming up. Estimate the caseloads. How many people am I seeing? How often am I seeing them? Therefore, how many people in a 35-hour week, a 40-hour week can I see? From your time study, what percentage of your staff will be billable time? How many 15-minute increments is that? That's commonly called in the Medicaid space, how many units of service have you generated? With a successful claim, you get paid that $27 for a 15-minute increment of supportive employment services. How many $27 payments have you rolled up there? And then estimate your productivity requirements. We already talked about that by staff member and by rate. Be realistic, be conservative. Don't burn your staff out. Don't say we expect 95% of your time is going to be billable. That's just not realistic. You want to make sure that they've got the time to be thinking about quality care. You want training, you want supervision, you want staff meeting, you want all kinds of other things. So think about that and use that use that productivity standard in order to determine your total cost of care and revenue generation. Next slide, please. Okay, how do we estimate caseload sizes? Well, how often do people need to be seen? How often are we able to see them under the revenue model? Do we have to go back and ask for additional time, additional units of service? Who are you serving? Are you serving individuals? Or are you serving families? Are you serving people with high behavioral health related needs? Are you serving with people who've never been employed versus people who've had lapses of employment? Are you serving youth? Are you serving families? Are you serving, all of these are different questions. Think about when you're estimating your caseload size. What's the best practice service model addressing the needs of the target population? What is that? For families, we generally say it's a 1 to 10 to 115 caseload. Chronically homeless, high behavioral health needs, that's often a 1 to 10 caseload. Homeless, engaged in services, that could be a higher caseload, 1 to 20, 1 to 25, etc. Make sure that there is the time, and this is what you learn from the time study process, to really spend the time with people they need. You want them to get the right amount of service. We think about as the right of dosage and attention of service. Not too much services, you've wasted time and money there. Not too little services, you've set people up to fail. You're always looking to try to figure out what's that right middle there. Are residents new to supportive housing? When people move into supportive housing, when people are new to jobs, they need more time. They need more hands-on attention. They need more care. How do you mix up caseloads so that people have a couple of new people? Nobody's ever got a whole new caseload, hopefully not, except maybe at the start of a program. Nobody's got, a coasting caseload where everybody's been here for 10 years and they just need check-ins, etc. You really want to mix, and you want to know what that factor calculated into your caseload side. Are your case managers new? Are they learning on the job? How are you supporting them in doing that? That's also going to be part of your caseload side. And this is scattered site or project based. Is it rural or urban? Remember, I said travel's not billable. That's a federal requirement. Washington State can't change that. That's literally an act of Congress, folks. And so you've got to estimate in that travel time. Remember, I said some people may only be billing at 40% of their time. A rural person who's got a caseload of 10 or 15 people, but over 3 different cities in three different towns in Eastern Washington, they're going to have a lot of travel time in there. So how do you make sure that that all is covered, or that they're generating enough revenue to cover? We can't cover travel. So yeah, so these are just some of the questions as you begin to think about what are the caseload sizes that are working for you and your agency. Hope this is helpful. Next slide, please. So here's all the things. We've talked a lot about productivity. We've said you want to get that number. Is that 40%? Is that 60? Is it 75%? Here's a whole bunch of things you've got to think about when you go into estimating those productivity standards. Everybody gets time off, paid time off, sick time, bereavement, vacation, whatever. Administrative tasks. Are they doing documentation and billing? Do they have tablets so they can just put a couple of clicks on their tablet and make this happen? Or do they have to go back to an office and write something down? That's generally speaking not billable time as well. Long-term engagement and outreach, collateral services, generally not billable. Everybody takes a lunch, everybody hires. We don't generate all this revenue in our first day, in our first week. We have to have a ramp up time. We have to usually partner, a more senior staff with those newer, greener staff in order to teach them the ropes. People need training and professional development time, and then building up time for those administrative tasks, authorizations, rejected claims, quality assurance, responding to your quality assurance person who says something about your documentation. All of that is things that will decrease that. You start at 100% billable, but after all these things happen, then you come down. Be conservative in your estimates. Don't burn out your staff. They work really hard. These are tough jobs. You want to give them a productivity target that is realistic and supports their growth and work. Just some thoughts on estimating productivity. Okay, first tool. So the first tool we're giving you is the simple budget forecasting tool, and that should have come in the email last week from Ava. It is a simple spreadsheet. It gives you basically, hey, how much does it cost? I never realized until I started doing these kinds of budgets that, hey, it doesn't cost my agency just my salary. It also costs them all of these fringe benefits. So we see John Doe, he's an employment specialist. He gets paid $30 an hour. He's working 28 hours a week. This gives him an annual salary of $62,400. But then you've got all these other taxes, life insurance, workers' comp, retirement, all these things that your agency's also paying for him. So you've got a number of fringe benefits. So even though John's only getting paid in his paycheck 62 a year, he's getting benefits and coverage totaling to 84 of an annual cost. So when you will look at the revenue that John's generating, you want to make sure that you figured out a model in which you can generate at least necessary more, probably that $84,000 a year. And again, spreadsheet coming to you in the website. It's also, I mean, in the email from Eva, it's also on SharePoint. Download it, modify these things. That's why they're all still, none of these are PDFs. They're all still Excels so that you can change them as you need for what your agency's costs are. Next slide, please. So direct services staff, same for everybody, but it's going to be a little bit different how you think about revenue generation from supported employment and supportive housing. That's because of the difference in what I call the payment mechanisms. Supportive employment is a 15-minute increment, units of service. So you want to do an estimate of how many units any given employee is generating a week, what the rate is, and then what revenue that generates. You're going to think about this differently for supportive housing. So you see 4 different staff here, 4 different percentages of billable time. This means this agency has done the time study. They figured out, okay, 50% is what works for us, 60% is what works for us. Here's how many hours a week you work. This is how many units of service with that percentage of time of your time billable. And then you get the revenue generation here. So we said the total annual cost for John from the staff forecasting tool was $84,000. That's salary and fringe. If he provides FCF services to break even, between 40 and 50% of his time needs to be billable, so that we're covering that 84. I just take out that 1959 reference, forgive me. We see the employee dedicating 50% of their time here will be generating a 98,000. Now remember, we had a slide here on these are all your startup costs. We had a slide here on remember these are all your ongoing costs. This is just paying one direct service worker. So when you see that 98, well, that 117,000, you're going to need to see numbers like that, because the difference between it costs 84,000 to employ John, but we're generating 98, that 14,000 is going to be covering all those other things, your billing people, your quality people, your electronic health record. All of those things need to be covered. And again, remember, it's going to come on the back end too. And forgive me on my wrong 1959 reference. I should have changed that. Sorry. Next slide, please. You guys can change it for yours. Next slide. So for the housing support workers, how many people do they see a day? That's where we can make edits every 10 slides. Thank you, Eva. My bad. And the, what was I gonna say? Oh, so how many residents do they see a day? Remember, housing support worker is billing on a per diem model. So if they see 2 people a day and there's 5 days in a week, that means they're billing for 10 people a day. That means on average, they're gonna be billing for 40 people a month. If they're doing 40 per diem billing at $112, that's gonna give you about $44.80 a month. Again, simple revenue projections here, some ideas. If they see more people a day, they spend more time, they've got more billable days, etc. More days billed a month, higher caseloads there. So you see an additional revenue generation there. So again, very similar, slightly different depending upon you're doing supported employment for the former. On this one, you're doing the latter. These are not interchangeable at this point, because again, what you're doing is because of the different payment mechanisms. Next slide, please. All right. CSH also has a services budget guide and a services budget guide tool. These were also sent out to everybody in Eva's last week. And this helps you generate all of the other all of the other costs. So all of the electronic health record costs, it gives you places where you estimate. We're not going to go into it in too much detail here, but this is something if people want to take a look at it and come back to the Q&A session. But you estimate these are the people we're serving. This is what our caseload's going to be. This is what we pay people. This is what this is the productivity requirements we put in. And then it helps you generate the revenue determination. Again, it's just building on that simple tool, but the simple tool is just based on your direct services work and making sure direct services worker are covering your costs. This broader services budget guide is thinking about all of the other administrative pieces that you need to cover into Medicaid and will help you start with the program budget, start with the revenue generation, start with all of the other costs that are part of that program budget, and make sure you're breaking even on the service and what it is that you need. Many things can be changed. You can change the rates. You can't change the rates for the state, but you can change different, you can change what you're paying people. You can say to the state, look, we need a higher rate for this. You can say, we're going to just have one person who does both QI and compliance and marketing. You can think about all different ways to do this creatively, and you can also put in your costs here. But again, the goal here is to help you understand your total, not just direct service worker, but your total cost of care. Next slide, please. So with that, I'm going to take a break. I think I'm going to take a sip of water and ask if there are any questions. And as you think about revenue projection questions, what information do you need in your agency? What information do you need to collect? Do you already have? What information do you need to collect? How do you take what you've learned here and go to the next steps for your agency and your agency's FCS program?
Hi, Marcella. This is Dawn Miller. How are you today?
Hey, Dawn, thank you for joining.
You bet. I just wanted to make mention of the topic we discussed briefly, that staff can bill for individuals on their supported employment caseload when they do employer outreach for specific individuals. Got to be the treatment plan objective, has to have a progress note attached to it. But something that's pretty unusual for Medicaid, and so worth mentioning.
Oh, no, I think that's really important. Remember, I had said before I wasn't sure about collateral and indirect and deferred to Rayanne and to you for supported employment. So that's really important. Thank you. Yeah.
And obviously, if anybody has questions about that, a pretty brief explanation, so feel free to reach out.
Yep, that's just true. Sample job descriptions, different positions in place for budgeting. We have, Audrey, we have some of those. Reach out to Eva. Eva will help you find these, etc., for a couple of different, but if you could just be more specific about what particular jobs and job roles, and knowing that we are the Corporation for Supportive Housing, we have more than a few examples on the housing side. We may not have them on the employment side. Dawn, would you have places where you could send people for sample job descriptions? Unsupported employment.
Not sure about places to spend them. I'd have to, or send them. I should can take a look at the Pathways to Employment website, but I do have some samples. So if they wanted to reach out to me, I can send what I've got.
That's great. Thank you.
But yeah, you are welcome to reach out to me if you're looking for job description samples. We can certainly share some from the supportive housing side.
Yep. And Katie, Dawn is asking for you to say again about the employer outreach is billable if, handing over to you.
Very good question. It has to be for a specific individual. So you have to have someone in mind when you go and do the job development. That person has to have a relevant objective in their treatment plan. And then you have to do a progress note. So that progress note has to have the billable time within it, within the coding section of the progress note. Hopefully that answered the question.
Yep, I think that does. Nikki's asking, is there help with applying for an NPI and getting an EHR? And what I would say is that if you go back to the slide deck, Nikki, for session 1, there is step-by-step guidance on getting an NPI. There is the forms and the websites and all of that, etc. In regard to getting an EHR, we will talk more about EHRs in in session 5, which focuses on billing and documentation. I will tell everybody this now, and everybody hears the same thing from me on that. CSH is not recommending any one EHR over any other. And quite honestly, I would suggest that you talk to other agencies that are doing a similar service to you, and asking what EHR did they use, what's valuable about it, what's helpful, etc. You want somebody to recommend or not recommend a system that somebody who is using that system every single day and their agency has to live and die on that system. So a lot of people recommend EHRs, a lot of people say good things or bad things about them. I always want to get my advice from somebody who's using them every day and has built a sustainable program using an EHR. So that is my EHR speech. You'll hear it again in session 5. Oh, yeah. These are really good questions, guys. What else? Again, all the tools are here. Take down the materials, adapt them. Our goal is to have you, be able to use them and adapt them as you will. None of these are copyrighted. We want you to all have and run with them. Anything that makes your life easier as a direct service provider is something we're happy here for. And I lost the slides. I think we may have 1 or 2 more slides.
We do. I just figured during this Q&A session, I would take the slides down so that if folks just wanted to come off camera and jump in, they would be welcome.
Oh, yes. I love that. Love to see faces.
But if no one has any questions, then I can bring the slides back up.
Cool. What else, folks? Okay, please remind me what session will documentation. Oh, go, Eva.
No, I was just going to read the question out loud, Marcella, which is exactly what you're doing. So please go ahead.
Okay. Remind me what session will be case documentation that meets billing requirements. That is session 5. Billing and documentation is session 5. So we are on session 3. Next week is policies and procedures. Session 4, that'll be Terry Power. And then I'll be back, and then I will be back with you on session 5 for documentation and billing. And all of these sessions are being recorded. They're available on the CSH SharePoint file right now, which folks hopefully have been able to access and pull materials down. And then they will be getting up someday soon on the Pathways to Housing. Yeah. All right, so this is just our ending for today. Alicia's been unable to access the SharePoint file. If you want to follow up with Eva, and let's figure out how to fix that for you. You did reach out to Eva. Okay.
Hi, Alicia. Yeah, it sounds like I reached out, or we both reached out to Josh. We can definitely go back in and follow up with him again. Yep. As of now, the only difference between what I've emailed out and what's in the SharePoint is that SharePoint contains the recordings from the first 2 sessions. So in the meantime, Alicia, if you have not received documents via email, I can definitely get you access to those while we wait for Josh to fix the technical glitch with getting you access. I'll follow up with him again.
Thank you. Good. All right. So we will see you again on Thursday at 11 a.m. Q&A session. Zoom training of all time. Wow, Katie, I'm just honored. I can't even believe. So I'll just stop with that. Q&A session on Thursday. So bring your questions about anything from session 3. This is a lot of material. This is very complicated material. We want you to be able to understand it. We want you to have the tools you need in order to do this work. So we'll do that. And then next week, session 4, policies and procedures. That is 9:30. And Christopher's asking for a registration link for the Q&A. Eva, do we have that? I know I have it, but I'm afraid if I give him my link, it'll make him a panelist.
Yes, the Zoom link should have gone out. Rayanne, was the Zoom link for Thursday emailed out to folks?
I do think so, but I'll find it, excuse me, and make sure that it goes out, and I'll send it to you too, Ava, if we can get it back out to folks.
Perfect, thank you. All right. So let me turn my camera back on to close out. Thank you so much, everyone, for tuning in again today. And I'm, as Marcella said, very thrilled to hear that this is Katie's favorite Zoom of all time. That's really quite an astonishing compliment. So thank you. We're so glad that this has been helpful for all of you. We look forward to seeing you on Thursday. Hopefully you guys can join. It looks like Rayanne just shared the link in the chat.
Thanks, Rayanne.
Thank you, Rayanne. I can also send out a follow-up email with the edited slides this afternoon. As you noticed, there were a couple typos referencing 1915I instead of FCS. That's a different authority for funding. So we want to make sure that we're using the right terminology with all of you. So I'll send those updated slides out along with the link for this Thursday's Q&A session. And then, of course, we have the following session 4 training next Tuesday at the same time. So again, thank you all so much for tuning in. Thank you, Marcella and Rayanne. And we'll see you all Thursday and the following Tuesday.
Thanks, Eva. Thanks, everybody. Have a great week.
Bye, everyone.